Occupational English test. Listening test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Doctor, thank you for seeing me today. I've been having some issues that I think need addressing, particularly with my Parkinson's and this persistent heartburn. It's been quite bothersome, especially at night. Every night around 11:30, I start feeling this burning sensation that just won't let up for about an hour.
I appreciate you bringing these concerns to me. Let's start with your Parkinson's disease symptoms. How have these been affecting your daily activities?
Well, my balance has been off, and I'm using the walker more now. My postural stability isn't what it used to be, and I'm afraid of falling. The medications help reduce the tremors, which is good, but these balance issues are quite new and a bit frightening.
That sounds challenging. How about your reflux? You mentioned it's particularly troublesome at night.
Yes, it's very consistent, always at the same time each night. I've tried adjusting my meal times and sizes, especially reducing sweets, but it doesn't seem to help much. Omeprazole and ranitidine have been part of my routine, but they're just not doing the job anymore.
Have you noticed any triggers that might be worsening your reflux besides food timings?
Not that I can tell. I follow a fairly consistent routine. Also, last night I experienced something new. My tongue and throat felt swollen. I thought it might be from the reflux.
Swelling could be concerning. It might be a reaction to something. We need to keep an eye on that. You also mentioned using Miralax for constipation. How is that working out for you?
It works, but I'm worried about becoming too dependent on it. I only use it when absolutely necessary, but even then I feel uneasy about it.
It's good to use it cautiously. Regarding your other medications, how often are you using your nasal spray, fluticasone?
I haven't refilled it recently because I haven't felt much need for it. My breathing has been okay, mostly.
Understood. And how are you managing your overall mobility and physical activity?
I'm attending physical therapy, which helps a bit. They've given me some exercises to do at home, which I try to follow regularly.
That's good to hear. Staying active is important, especially for managing Parkinson's symptoms. Now let's review some of your recent clinical measurements and lab results to better understand your current health status.
Please go ahead, doctor.
Your weight has decreased significantly, which is good considering your heart condition, but we need to ensure it's a healthy weight loss. Your blood pressure is fairly controlled at 135/85 mmHg, which is within the target for your age. Your heart rate and respiratory rate are also within normal limits.
I'm glad to hear that at least some things are on track.
Yes, but there are a couple of areas we need to monitor closely. Your latest lab results show your kidney function is slightly reduced, with an eGFR of 55 milliliters per mins for 1.73 meters squared, which is expected at your age, but still requires us to be cautious with medication dosages. Your cholesterol levels are somewhat elevated, and we should discuss dietary strategies to manage this.
I see. Is there anything specific you recommend?
We can discuss that in detail in a bit. Your thyroid-stimulating hormone is a bit high at 5.8 μIU mmol, which suggests your thyroid might be underactive. We might need to adjust your thyroid medication accordingly.
Okay, that makes sense.
Now, based on your concerns and these findings, here's what I suggest. We will need to perform an INR test immediately to check your blood's clotting status, especially important since you've had surgery in the past and are on multiple medications. I recommend transitioning from omeprazole to pantoprazole for your reflux to see if this offers you better relief. This should be taken 30 minutes before meals.
And if the symptoms still don't improve?
If the symptoms persist, we should consider increasing the dose or possibly adding another type of medication to help manage your reflux more effectively. Also, I will schedule a follow-up with a neurologist to evaluate and potentially adjust your Parkinson's medications, given your concerns about balance and mobility.
Thank you, doctor. I appreciate your help in managing all these issues.
It's important to take a comprehensive approach, especially given your complex health needs. We'll keep monitoring closely and adjust as necessary. Let's make sure to schedule your next appointment on your way out today.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Doctor, I've been coming here for a while now, and this pain just doesn't seem to get any better. It's been a constant battle, especially in my shoulders and down my spine. It seems like every little movement just triggers more discomfort. Over the years, I've tried everything from chiropractic sessions to physical therapy, but nothing gives long-term relief.
I understand your frustration. It's important that we keep exploring options that could help alleviate your symptoms. You mentioned using various treatments in the past. Can you tell me more about those experiences and how they impacted your pain?
Well, initially the chiropractic care seemed to help a bit with my spine, especially the lower back. But the relief was always temporary. Physical therapy was similar. I felt a bit better right after the sessions, but the pain would come back soon after. I've been on different pain medications over the years. I remember taking Atodolac for a while, and now there's this other pain medication. I'm just worried about the long-term effects, especially on my liver.
That's a valid concern, especially with your history of using medications like Atodolac, which can indeed impact your liver with long-term use. You also mentioned emergency room visits due to severe pain. What usually happens during those episodes?
Those are the worst. The pain becomes unbearable, almost like a sharp stabbing that doesn't go away. Each time, they usually give me something strong for the pain and sometimes muscle relaxers. It helps at the moment, but I'm here now, still struggling with this daily.
Thank you for sharing that. It's clear the impact this is having on your daily life. You also had an MRI recently on your right shoulder. What did the doctors say about that?
They mentioned degenerative changes in the acromioclavicular joint. I guess it's part of why my shoulder hurts so much. They suggested continuing with physical therapy and maybe trying some topical treatments like capsaicin cream to see if it helps with the surface pain.
Using a topical agent might be a good approach to manage localized pain without the systemic side effects of oral medications. I noticed you've been using a heating pad too. Does that provide any relief?
Yes, it does help a little. It's soothing and tends to ease the pain a bit, especially at night. I try to balance that with some light exercises, like using weights to strengthen my upper body. It's tough, but I'm trying to keep my muscles from getting stiff.
It's great to hear you're taking proactive steps with exercise and heat therapy. Maintaining muscle strength and flexibility can be beneficial in managing chronic pain. Let's go over your recent lab results and see where we stand. Your blood pressure and blood glucose levels are within a reasonable range, though your glucose is on the higher side, which we need to monitor, considering your diabetes.
I've been trying to manage my diabetes with my diet and insulin, but it's a lot to juggle, especially with these pain issues.
Absolutely. It can be quite challenging to manage both conditions. Your lab results show stable kidney and liver function, which is good news, especially given your concerns about medication effects. For your pain management, considering your liver health and previous experiences, tramadol might be an option. It's less likely to cause liver issues compared to NSAIDs and might be effective for your pain type.
I'm willing to try anything that might help at this point.
I'd like us to proceed with a cautious trial of tramadol. Additionally, I recommend continuing with physical therapy as it can provide some relief and improve function over time. We should also reevaluate the effectiveness of the capsaicin cream after 2 months. It's important to keep track of your symptoms during this period.
Sounds like a plan. I appreciate you helping me figure this out.
Of course. Let's schedule a follow-up in 2 months. I'd like you to bring a log of your pain levels and any episodes of severe pain, as well as your blood sugar readings. It's crucial that we keep a close eye on both your pain management and diabetes control.
Will do, doctor. Thank you for taking the time to go through all this with me.
You're welcome. I'm here to support you through this. See you in 2 months or sooner if your symptoms worsen.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Good morning, everyone. Today, I want to talk about promoting mental health awareness and reducing stigma in our workplace. It's crucial that we create a supportive environment where everyone feels safe to discuss their mental health without fear of judgment.
Absolutely. And I think training sessions on mental health literacy could really help us all understand the signs of mental distress and how to approach someone who might need help.
That's a great point. We can also establish a peer support system where employees can volunteer to be trained to offer initial support and guidance to their colleagues.
Implementing regular check-ins can also be beneficial. Just having a manager or a peer touch base regularly can make a big difference in how supported an employee feels.
Let's not forget the importance of access to professional resources. Ensuring that our team has access to mental health professionals or counseling services is key.
Thank you for bringing this up today. I think these steps could really change our workplace culture for the better.
Now look at question 26.
I understand that being diagnosed with diabetes can feel overwhelming, but I want you to know that you're not alone in this. We're going to tackle this together.
It's just a lot. I'm worried about what this means for my everyday life. Can I still do things like hang out with my friends?
Absolutely. You can still do all the things you love. Managing diabetes will require some changes, like monitoring your blood sugar and being mindful of your diet, but it doesn't have to stop you from living your life.
What about sports? I play basketball with my school team.
You can definitely keep playing basketball. Physical activity is actually good for managing your diabetes. We might just need to adjust your treatment plan to fit your activity level.
That sounds okay, I guess. It's just going to take some getting used to.
It will, but I'll be here to help you through it, and we'll make sure you have all the support you need.
Now look at question 27.
Let's discuss how we can manage both acute and chronic pain effectively. It's important to understand the differences in treatment approaches.
For acute pain, short-term medications and physical therapies can be effective. But chronic pain often requires a more comprehensive approach, right?
Exactly. Chronic pain management might include medications, physical therapy, and even psychological therapies to help manage the stress that comes with long-term pain.
I've read about the role of lifestyle changes too, like diet and exercise. How significant are those?
Very significant. A healthy lifestyle can reduce inflammation and improve overall pain management. Incorporating regular exercise and a balanced diet can make a substantial difference.
It sounds like a multidisciplinary approach is best. Should we consider alternative therapies as well?
Absolutely. Treatments like acupuncture, massage, and even mindfulness meditation have shown promising results in pain management.
Now look at question 28.
I have some positive news about your prognosis. The treatments have been working well, and we're seeing great progress in your recovery. This is a significant step forward.
Really, that's such a relief to hear. I've been so worried.
I understand your concern, but the results from your latest tests show improvement. We should continue with the current treatment plan, as it's proving effective.
What should I expect in the coming months?
We'll keep monitoring your progress closely, but if things continue this way, we can expect a continual improvement in your condition. We'll also adjust treatments as needed to ensure the best outcome.
Thank you for keeping me updated and for the encouragement. It means a lot to me.
Of course, it's important to focus on these positive developments. Staying optimistic can actually play a big part in your health journey.
Now look at question 29.
Today we need to address the unique challenges posed by sickle cell disease. It's not just about managing pain. There are multiple factors to consider in daily management.
Exactly. Issues like anemia, frequent infections, and episodes of pain, known as pain crises, require a comprehensive management strategy.
Right, and we must consider the psychosocial impact as well. The unpredictability of pain crises can lead to anxiety and stress, which can exacerbate health issues.
That's why routine follow-ups and a solid support system are crucial. Patients need consistent care and should feel supported both medically and emotionally.
We also need to educate schools and workplaces about the disease to ensure that individuals receive the necessary accommodations.
Absolutely, awareness and understanding from the community are vital to improving the quality of life for those with sickle cell disease.
Now look at question 30.
Adapting to a new lifestyle after your diagnosis is crucial for your treatment and recovery. Let's discuss how you can manage this transition effectively.
I'm willing to do whatever it takes, but I'm not sure what I should be focusing on. What are the most important changes?
First, it's about maintaining a healthy diet and staying active as much as your condition allows. This can significantly affect your energy levels and overall health.
I've heard stress management is also important.
Yes, absolutely. Stress can affect your immune system, so finding ways to manage stress, like through meditation, yoga, or even hobbies, is very beneficial.
What about support from others? How important is that?
Very important. Having a support network, whether it's family, friends, or support groups, can provide you with emotional resilience and practical help during your treatment.
That is the end of part B. Now look at part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at extract 1.
Welcome everyone. Our focus today is on an essential and evolving area of pediatric healthcare, the management of neonatal infections. Let's dive into their implications through a detailed case study. Our case today involves a 21-day-old neonate who presents with a fever of 38.5 degrees Celsius and appears well but irritable, with the only other symptom being mild nasal congestion. This situation is a common yet complex challenge in neonatal care, requiring precise and informed decision-making to ensure optimal outcomes. According to the latest updates discussed by Dr. Mark, there has been a significant shift in the epidemiology of neonatal infections. While Group B Streptococcus was historically a leading cause, its incidence has declined due to effective maternal antibiotic prophylaxis. Currently, E. coli has emerged as a predominant pathogen, especially in neonatal bacteremia. Moreover, vaccinations have reduced diseases like pneumococcal infections in young infants, significantly altering the landscape of neonatal infectious diseases. Given these changes, the approach to a febrile infant like our case must be methodical and evidence-based. The New American Academy of Pediatrics, AAP, guidelines recommend a comprehensive initial workup for infants younger than 28 days who present with fever. This would include collecting blood cultures, a urine analysis, and considering a lumbar puncture, especially if the infant displays any signs of irritability or lethargy, which could suggest meningitis. The rationale for such a thorough approach in our case is based on the still considerable risk of serious bacterial infections in very young infants. The guidelines emphasize the use of inflammatory markers such as C-reactive protein, CRP, and procalcitonin to guide further interventions. Elevated levels of these markers can indicate a bacterial infection, necessitating aggressive management, including possible lumbar puncture and empirical antibiotic treatment pending culture results. Let's assume that in our case, the CRP is elevated and the medical team performs a lumbar puncture. If the cerebrospinal fluid, CSF, analysis is abnormal, this would confirm the need for initiating antibiotic therapy while awaiting further culture data. This step is crucial because early intervention in cases of bacterial meningitis can be life-saving and prevent severe complications. However, it's also important to consider the advancements in diagnostic capabilities that Dr. Mark mentioned, such as comprehensive viral panels. These tools allow clinicians to identify specific viral causes of fever, which are far more common than bacterial causes in febrile infants. If our case returns a positive result for a common viral infection, this would significantly influence the management approach, potentially allowing for more conservative treatment and avoiding unnecessary antibiotics. This nuanced approach to diagnosis and management reflects a broader shift towards personalized medicine in pediatrics, guided by both clinical judgment and technological advancements. The new guidelines encourage pediatricians to balance intervention with caution, aiming to protect infants from overtreatment and its associated risks. Implementing these guidelines effectively requires understanding local epidemiology and resource availability. The reality is that not all healthcare settings have immediate access to rapid diagnostic tests or the capability to quickly process laboratory results. This variability can influence how closely guidelines are followed and how decisions are made on the ground. The revised guidelines for the management of febrile infants represent a significant step forward in pediatric healthcare. They provide a framework that supports more targeted and judicious use of medical resources, reducing unnecessary interventions while safeguarding against the risk of serious infections. As we've explored through our case study, each decision point in the guidelines is backed by a growing body of evidence that enhances our ability to deliver care that is both effective and considerate of the young patient's needs. Thank you for your attention.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Hello everyone. Today we continue discussing practice-changing guidelines with a focus on the management of venous thromboembolic disease, or VTE. These guidelines, recently published, were developed by the American College of Chest Physicians. Joining us today is Dr. Alex Hoobs, an Associate Dean and Professor of Medicine at the University of Alberta. Dr. Hobbs, thank you for joining us.
Thank you, Penny. I'm excited to be here and discuss these important updates.
Dr. Hobbs, could you start by sharing your experience as a member of the Guidelines Committee? What was that like?
Absolutely, Penny. Being part of the Guidelines Committee was both an honor and a profound learning experience. I've been involved with the American College of Chest Physicians for many years, but taking on the role for the antithrombotic guidelines since 2014 has been particularly enriching. Initially, I contributed to a chapter on heparin-induced thrombocytopenia in the 2012 guidelines, which was my first deep dive into how evidence is rigorously applied in guideline development. From there, my role expanded, and I was tasked with overseeing our antithrombotic portfolio. It's been challenging but incredibly rewarding, especially as we prepared for the recent 2021 update.
It sounds like you've been deeply involved in shaping these guidelines. For our listeners, especially those in clinical practice, could you highlight the key PICO questions addressed in this update?
Certainly. The PICO questions form the backbone of guideline development. They focus on practical dilemmas clinicians face daily. This update centered on critical issues like who should receive treatment for VTE, the optimal treatment strategies, and the duration of therapy. Additionally, we tackled newer questions such as the management of incidental pulmonary embolism and the unique treatment considerations for patients with antiphospholipid antibody syndrome. These questions help us provide targeted guidance that can directly impact patient care.
That's very insightful. Now let's discuss VTE in more detail. Could you give us a brief overview, especially for our listeners at various training levels?
Of course. Venous thromboembolism, or VTE, encompasses both deep vein thrombosis, DVT, and pulmonary embolism. DVTs typically form in the deep veins of the legs, and if a clot breaks loose, it can travel to the lungs, causing a PE. It's important to understand that not all lung clots originate from the legs. Some form directly in the pulmonary arteries. VTE is essentially a spectrum of the same disease affecting different parts of the body.
Thank you for that explanation. Let's apply this to a hypothetical patient, Mr. C, a 72-year-old with advanced colorectal cancer, undergoing chemotherapy. He presents with acute chest pain and shortness of breath. The emergency department diagnoses him with a PE. How would you approach risk stratification in this case?
Risk stratification is crucial. It helps determine the appropriate setting and intensity of care. For Mr. C, factors like his age, cancer diagnosis, and symptoms suggest a higher risk category, which influences both the immediate treatment strategy and ongoing management decisions. Utilizing tools like the Pulmonary Embolism Severity Index, PSI, or the simplified version can help in making these decisions.
With Mr. C's diagnosis, what are the guidelines recommendations for managing different risk categories of PE?
The guidelines delineate clear management strategies based on risk stratification. Low-risk patients might be suitable for outpatient treatment, whereas high-risk patients, like those with massive PE and shock, should receive more aggressive treatments such as thrombolysis if there are no contraindications. For someone like Mr. C, who falls into a higher risk category but is not in shock, the initial approach would include close monitoring and anticoagulation in a hospital setting.
And how does Mr. C's active cancer influence the choice of anticoagulant for long-term management?
Active cancer significantly influences anticoagulant choice. Historically, low molecular weight heparin was preferred for cancer-associated thrombosis due to lower risks of recurrence compared to vitamin K antagonists. However, recent studies suggest that certain direct oral anticoagulants may be equally effective and could offer benefits like lower risk of major bleeding. For Mr. C, a direct oral anticoagulant could be considered, particularly if his type of cancer and overall health status align with the findings from these studies.
Dr. Hobbs, this has been incredibly informative. Any final thoughts or key points you'd like to emphasize from the guidelines?
The key takeaway is the importance of personalized care in managing VTE. The guidelines provide a framework, but each patient's unique circumstances must guide their application. I encourage clinicians to refer to the full document for a comprehensive understanding of the rationale behind each recommendation. It's all about balancing the benefits of treatment against potential risks, with the ultimate goal of optimizing patient outcomes.
Thank you, Dr. Hobbs, for sharing your expertise with us today.
Thank you, Penny. It was a pleasure to discuss these critical updates and how they can help improve patient care in the realm of venous thromboembolism.